time with the live video. I don't know why it's not working. Hmm. All right. Is there anything pop up there? Yeah, and there's nothing that popped up as far as it says you're watching. It should be able to have an invite to join. Hmm. I'm gonna try it. I'm gonna try it one more time on the lap. I don't know if I should try it on the laptop or not. Yeah, it says invite a friend to be in your broadcast, and that's what I used last time. I don't know why it's not. I put the request in. Let's say I did it one more time. It should be working. Business. Maybe I should log out and do it as Iden's Fitness. Hmm. Okay. Let me see. Let's see. Oh, okay. All right. I see you can comment. Are you able to log into the video screen though? Hmm. Huh. If it has it now. Okay. Let's see. Ah, we got a winner. All right. Finally. All right. Okay.
So okay. On my cell phone.
All right. I'll end our phone conversation so we don't. Good. Okay. Very pleased to have on Dr. Vladimir Sinkov. He's an orthopedic surgeon and he specializes in minimally invasive spinal surgery. He's been kind enough to join us and go over some different topics as they relate to spinal health, exercising, fitness, back pain, things like that. So let's see. So they have a variety of topics we're going to go over. And I guess the first one would be, why don't you just introduce yourself, doctor, and kind of give yourself the your background and what you've and what exactly you do.
Sure. Then I hear you very poorly. I'm still trying to work on my phone, trying to increase the volume. I don't want to hold it.
I can hear you.
Can you hear me well?
Yep.
Okay, perfect. All right. So my name is Vladimir Sinkov. I'm an orthopedic spine surgeon. I've graduated spine fellowship in 2010. I practiced spine surgery in New Hampshire for about 8 years. Then about a year ago, we decided to move to Nevada. So I've been here for 1 year now, practicing with Nevada Orthopedics and Spine Center.
Okay. And so what type of, I guess a good thing would be what type of different, I guess what type of different patients are the most common that you see that you work with that come in? What type of issues are they having?
So most common patients I see are adults. I don't really do pediatric spine surgery. That's kind of a separate subspecialty, so to speak. So Most I see adults with degenerative spine conditions, even though degenerative sounds like something that has to happen at old age, it does actually happen in younger people as well. So average population of people I see are from 40 years old and on. Rarely I would get a 20 or 30-year-old. That'll be usually more of an acute spine injury, such as a sprain, strain, sometimes a disc herniation.
Okay.
Sometimes I see overuse injuries causing stress fractures in the spine. That's usually in their 20s.
Okay. What type of overuse injuries do you tend to see when you're speaking to overuse injuries?
Sure. Well, the overuse injury specifically I'm referring to is called a Parse fracture or Parse defect. It is an actual fracture that can happen in your spine, but it's not a fracture that you typically get with high energy injuries, such as falling out of the window or car crash. Stress fractures are cumulative trauma. So typically what happens is if you do any kind of sport where you do a lot of backward bending, and unfortunately do it in a lot of sports,
yeah.
Most famous one for that is pole vaulting and cheerleading, but it technically can happen, and gymnastics, but typically can happen in a lot of sports, even basketball. A lot of them you do a lot of backward bending. So whenever you bend backwards, you put a little bit of stress on the bone in your spine called pars. And whenever you put stress in any bone of your body throughout their entire life, there are little microscopic cracks that you accumulate in them, which sounds scary, but it's actually completely not a big deal. The skeleton is completely prepared to deal with that. Our bone is a live organ, so whenever those cracks happen, the bone basically heals them all the time. Stress fracture happens when you start accumulating those cracks faster than your body's ability to fix them. Eventually, enough of them will accumulate that you develop a true fracture, and then it really starts hurting.
Okay. And so what's when you see people that come in, how does for a lot of the people that are in the group here, a lot of people are it's fitness oriented, exercise. How much does, say, someone being overweight, when you see that, how much does that affect spinal health, and what kind of issues do people tend to have? Especially
I'm sorry, I
obesity.
just finally got my sound back. Can you repeat the question? I'm sorry.
Okay, no, it's okay. Now, with our group, and this is a fitness group, and there's a lot of health and fitness questions. Anytime with fitness, there's always going to be fat loss questions or concerns. How much does being overweight affect spinal health? How much do you see of that? And in particular, how much does abdominal obesity affect spinal health?
Yes. So overweight, we have to specify overweight meaning not just high BMI, but precisely fat, because there are some people who have very high
like
body mass index, but it is actually because they accumulate a lot of muscle mass, and that's a completely different animal. Obviously, those people typically don't have back injuries because the muscles protect everything, but typically most overweight people are because they're gaining fat, and often the fat accumulates in the front in your abdomen. So mechanically what happens, obviously, since it's in the front of the body, it will start pulling the body forward.
Okay.
So for you to be able to walk upright, you have your muscles in the back of your spine, your paraspinal muscles, your buttock muscles, have to work stronger and have to work harder to just keep you upright. Typically speaking, whenever you gain weight, not only you physically adding fat to it, but typically it is people who are less active. So on top of that, they're getting muscle deconditioning because they're not moving much. So now you have a muscle that is in less of a good shape than it used to be and is now subjected to greater stress. So it is not uncommon for people, just because they have this anterior abdominal fat, to have more back pain simply because muscles are overworked. When muscles are overworked, they fatigue and they go into spasm because of inflammation. And if you use them long enough time, you basically run out of oxygen, muscle goes into cramp. So it hurts, you sit down, you rest, the pain goes away, and you can move again. But unless you either decrease stress on the muscle by losing the weight, or you strengthen the muscle, preferably do both, the pain will continue. It will be basically the cycle.
And then what if, say, if people do not continue lose weight or do anything to strengthen, their back or anything, what are the next progressions that you tend to see as far as spine related?
Sure. So initial thing is just muscular pain, the back pain that people typically feel. It's not right in the middle of the back, but it's a little bit off to the sides, over the sides of your pelvis. Specifically where you start having pain is what's called PSIS, posterior superior iliac spine. That's where a lot of your paraspinal muscles attached to the pelvis. Typically, when muscle goes into spasm, it's going to start hurting at the spot where it attaches to the bone. So that's the typical first thing to happen. Obviously, if you continue with that,
they're
then
feeling it by the hip? In the hip
no, they're
area?
feeling it basically in your lower back, but not right in the middle, but a little bit off to the side, either one or the other side or both. Kind of your upper portion of your buttock is where that is located.
Okay.
So, but if you basically ignore it, decrease your activity, which will decrease the pain, but you continue walking with this weight pulling you forward, you will start walking slightly bent forward, which makes it actually easier on the muscles in the back because they don't have to work as hard. You're shifting your center of gravity a little bit. But the more you bend forward, the more you start loading the discs in your spine, and you're starting to overload them. Once again, you already gain weight, so by that itself, you're already overloading the spine. But now if you're starting to walk bent forward, trying to relieve the pain in the back, you are loading the discs more, so now they will degenerate faster. So you start having this degenerative disc disease cascade. Unfortunately, once the disc starts degenerating, it will continue degenerating. It's just a matter of how quickly it will happen. And obviously, the less healthy, the less in shape, and the more overweight you are, the faster the discs will degenerate.
Okay. So yeah, it's definitely being in shape and having, keeping the body lean, especially abdominal obesity and abdominal fat is definitely a big role in probably a lot of spinal health. So that's
absolutely, and obviously not just spinal health, your cardiovascular health.
Yes.
The visceral fat, abdominal fat is also predisposing you to strokes, heart attacks, and many other problems. So overall, not the best thing for your health.
Yeah, absolutely, absolutely. What besides losing the body fat and so forth, what type of things would you recommend as far as for someone that wants to ensure, especially maybe as they get older, that they have good spinal health and that they're ensuring that their spine and their disc and everything are basically healthy as they get older? Sure.
So unfortunately, as you get older, your discs will eventually degenerate. Just like any joint in your body, eventually wear and tear will accumulate, but it can either happen faster or slower. And to slow down the progression of just normal age-related degeneration, the key things for spinal health are two. One is a range of motion. You got to make sure your muscles are not stiff, so you have proper motion of your spine. And the second one is core strengthening, core muscles, which are your abdominal muscles, your paraspinal muscles in the back, and psoas muscles, which run on either side of the spine directly. The stronger those muscles are and the better range of motion you have, the less likely the muscles are to hurt, the more likely the muscles are to keep you in the proper posture. Because of that, you're not going to be overloading your discs or your facet joints in the back unevenly, and you will minimize the rate of progression of arthritis and pain and disability that comes with it in your spine.
Gotcha. So basically, not just obviously for everyone listening, being overweight and preventing any abdominal obesity, but strengthening those areas as well, not just body, but strengthening the muscles in the midsection, the lower back, and you even were saying muscles like the psoas and the hip flexor muscles too, and anything I guess in the hip complex as well. Okay. Are there any certain? A lot of people will. I think one of the big things you'll see, lower back pain is one of the big things that people will complain about. Besides, obviously we talked about obesity and being overweight. What are some of the other things you see that when people come in with that have had lower back pain or lower back issues, is it not lifting correctly? Is it not bending when they go to pick up something, doing household stuff? Is it exercise? What are some of the common things that have people getting the lower back pain? It seems to be pretty common.
Sure, absolutely, yeah. Basically, all of the above, what you said. Any kind of motion that would unevenly stress them, either muscles in the spines or joints or the disc, can result in back pain. So not lifting correctly is probably most common one when people bend with their back, not with their knees.
With their legs,
if you carry a heavy load further away from the body, creating a stronger lever arm, which creates more pressure in the disc. If you twist your spine without twisting your pelvis and you don't really have good range of motion, if your muscles are tight and you still go through that motion, then that stress will translate to the disc. You may either injure the lining of the disc, or you can actually herniate the disc out if you create too much pressure in the disc. The disc is not a homogeneous structure. You have the soft inner portion that does all the cushioning and a tough outer covering that holds it together between the two vertebrae and connects the vertebrae together. So the way I explain it to the patient is basically like a really tough jelly donut with the jelly on the inside. But
Gotcha.
even with the tough outer covering being tough, if you create enough pressure, you can squirt some of the jelly out, and that's the disc herniation that people talk about, which can cause back pain, leg pain. So improper contraction of the muscles from poor body mechanics, be it household activities, golfing, lifting something heavy while moving, or doing exercise in the gym, can cause a disc herniation. So that's one of the things I typically see people for. More common, before you herniate the disc, people typically strain their back muscles. People don't really come to see me for that, since that's usually a self-limiting thing. Within several weeks, muscle strain usually goes away. Yeah. So typically you see me if it's persistent nagging and it's not going away.
Gotcha. Now you were saying was about how you can, with the lower back pain, it can start radiating down into the legs. Are there any when you have lower back pain, it may not be specifically, resulting in, that may be not the direct cause of it. What are some of the other areas, not just lower back, but back pain in general? Sure. What are some of the other areas that may be causing that and affecting that pain?
Yep. So yes, back pain is not a very specific symptom, and a lot of structures in your torso or in your pelvis can actually cause that. So injury to the back muscles or arthritis in the joints or the disc in the spine is a common reason for that. But other symptoms can also, diseases can also present with a symptom of just back pain. One of the other very common ones is hip arthritis. When people have hip arthritis, most classic pain for that is a pain anteriorly in the front of your body in the groin. However, it does not have to be like that. It can be just radiating pain in the buttock, and sometimes it does radiate up into your lower back. So people with hip arthritis sometimes come and see me thinking it is their lower back. I examine them. There's really nothing going on with the back. They have great range of motion. The muscles don't seem to be in a spasm. I start moving their hip around, and they wince in pain, and we get an x-ray, and for sure you have a complete deterioration of the hip, and you have bone rubbing on bone there. Completely separate disease, but presented with exactly the same symptoms. Another one that's
I have arthritis in my hip, so that's me.
There you go. Yep. So another one that's actually more frequently overlooked, and a lot of clinicians don't really think about it, is called sacroiliac joint inflammation or arthritis or pain. Okay. Sacroiliac joint is basically a joint between your spine and your hip joint. It connects the entire spine to the pelvis. So the bottom of your spine, the sacrum, is kind of like a triangle, a wedge, and it's sitting inside the pelvis. So you have two joints, one on each side, connecting your spine to the pelvis together. That joint is a very large but fairly flat joint. It moves very little. There are a lot of strong ligaments around it. It maybe moves 2 to 4 degrees. Most people, unless you're trained exercise physiologist, physical therapist, or chiropractor, are not even aware that there's a joint there. But even though there's very little motion there, you can injure the joint. It can become arthritic, and you can start having pain there. One of the most common ways that joint actually inflames is in pregnant women. Whenever they're getting close to delivery, they have this hormone that gets secreted called pitocin that actually makes all the ligaments looser, so it's easier to deliver babies. So the ligaments around the sacroiliac joint become loose. The joint starts moving more than it's supposed to. So it's very common for pregnant women close to delivery or right after it to have the sacroiliac joint pain. Fortunately, once they stop producing that hormone, the ligaments tighten up, the joint stabilizes, and that pain 99% of the time goes away. But that's actually the most common reason people have sacroiliac joint pain. You can also injure the joint. It is basically in your buttocks, so you fall on your buttocks forcefully on a hard floor or on ice, which I saw in New Hampshire a lot. You can actually directly injure that SI joint, sacroiliac joint, and it can hurt a lot. The pain is basically buttock pain and back pain, mimics the same back pain you would have from degenerative disc disease or disc herniation. So I see a lot of people that come to me with having been diagnosed with back pain. They get an x-ray which shows a little bit of disc herniation in the back, disc degeneration in the back, and they think that's it, their back. And I examine it, it's actually a sacroiliac joint. A lot of clinicians, unfortunately, don't examine that joint. There are specific separate exam maneuvers you can do to figure out, is it your back or is it sacroiliac joint? But that's another common one that I see. Another reason people may present with back pain is what's called trochanteric bursitis. It's actually typically pain on the side of your hip where you have what's called trochanteric bursa. It's a small sac of fluid that lubricates the space between the greater trochanter, which is the side of your hip joint, side of your femur, actually, not the hip joint, and the muscle that goes over it called IT band. Typically that bursa, that sac of fluid, just sits there, does nothing, you can't feel it, it just lubricates things. If you don't walk properly for whatever reason, you sprained your ankle, you have back pain, you have some knee pain, improper walking, improper mechanics for a long period of time will actually cause inflammation in that bursa. It will hurt on the side of the hip, but that pain once again can radiate up into the back. So that's another reason I sometimes see people for what they think and their primary care doctor think is back pain, but it's trochanteric bursitis. Completely different treatment. Basically, first you have to figure out why they're not walking properly. Once you fix that, typically bursitis goes away.
Okay, so now what type of different types of muscle imbalances do you see? I tend to, when I look at clients, I mean, one of the things I like to do is I do a postural assessment. I do a flexibility assessment. So I'm trying to look to see different areas or movement analysis, different areas that may be weak with a muscle or an area that's tight or that's weak. I tend to see a lot of tight hip flexors a lot, tight ankles, and then also tight internal rotators, tight pecs, and then, consequently, because the tight hip flexors, the weak gluteals, they just aren't firing correctly. They have the weak scapular retractors in the mid upper back muscles, and then the ankle mobility. I tend to see a lot of that being weak too. What, if any of those that I just mentioned, or any other imbalances or areas that are tight, tend to lead to some of the different back issues?
Yeah, basically what you said. Typically when we see imbalance, it is.
Oh, lost you there. We lost Doc. Hopefully we'll be able to log back in here. Okay, he's logging back on here.
All right, sorry, I think I'm back. I have no idea what happened.
You're back. Yep, we got you.
All right, so as a society, especially in more developed countries, we now move actually less, we sit more. Whenever you sit, you're really not using your extensor muscles much. You're not using your gluteals, you're not using your paraspinals. So that's one of the most common reasons hip flexors get tight. You also get tightness in your anterior neck muscles because we're bending our neck forward more and more because we're looking at computer screens, we're looking at cell phones. There's actually now a medical term, text neck, when you have posterior pain in the back of your neck because those muscles are overworked and going spasm because you're constantly bending your neck forward and not exercising them properly.
Mm-hmm. Okay.
So those are basically kind of flex forward position is the most typical postural abnormality I see. So the treatment for that is basically try and strengthen your extensor muscles and try and stretch your flexor muscles. So stretching your hip flexors and stretching your gluteals and your paraspinal muscles, that typically fixes that. And teaching patients about postural control. If you have to sit for work, try and sit up and stand up and stretch and walk around more. When you're walking, try and keep your spine in lordosis and extended, not leaning forward when you're walking. If you do look at screens a lot, try to adjust the screen angle or your seat so you're looking forward, not looking down. Typically, those are the recommendations I give, and probably similar to what you say.
Okay, so that sounds like I'm on the right track with a lot of the stuff I do with clients. As far as I explain it simply as if we have an area that's tight, we stretch it. If we have the opposing area, usually the antagonist or opposite muscle that's weak, and we work on strengthening that.
Exactly. Exactly.
And then, so you were saying back on posture stuff. What type of things posture-wise, in addition to what you were saying, do you recommend you have people do? Are there any certain stretches or things besides posture, flexibility things that you have certain patients do at all, or that you recommend?
Particular exercises I typically leave to a physical therapist and or their personal trainer, or sometimes a chiropractor to teach them particular exercises. Just from time limitation in the office, it is hard for me to show them the exercises to do. I try and do a little bit, but basically, if they're bad enough, they're coming to me. That usually means the problem has been going on for a long time, and just me showing them stretching doesn't usually help. I send them to a physical therapist who can do a lot more comprehensive treatment analysis and teach them how to do it properly. But basically what I just said, you know, trying to stretch your paraspinal muscles, your psoas muscle, your abdominal muscles. If they have greater trochanteric bursitis, I have them stretch the IT band so it does not get tight, which is what squeezes the trochanteric bursa, it causes that pain. And stretching calf muscles, which also typically get tight and create poor gait, which will in turn create back pain. A lot of people come to me with pain in their foot that they think is nerve pain, but is actually plantar fasciitis because their gastric muscles, the calf muscles are very tight. So just stretching those typically makes that go away, and stretching your hamstrings, which are tight on almost everybody I see.
Yep, I see it a lot. Yep. Yeah, and then for those that don't know, the IT band basically just runs along the outer sweep of your thighs there.
Yes. Yeah, it goes from your pelvis all the way down to the knee.
So why don't we go into what different procedures do you do? I know I posted the article that was basically, it was very interesting. You're talking about how different, different approaches to surgery, not with trying to improve upon the standard fusing of the spine and going with more of the disc replacement. What other different surgeries or newer different practices do you do?
Sure. So basically, those are kind of my two passions. One is disc replacement instead of fusion. It works great in the cervical spine. Unfortunately, so far with the implants and techniques we have not gotten as good of results in the lumbar spine. In lumbar spine right now, results for disc replacement and fusion, according to most studies, are equivalent, but the complications with disc replacement in lumbar spine are actually a little bit higher. So I haven't really done that many of those. I did some in the past, but it's really hard to find the proper candidate. And right now, it's not a great procedure. I'm sure in the future it will become as good as a cervical disc replacement. But in lumbar spine, unfortunately, fusion is still the most reliable way to treat it if somebody needs the entire disc to be removed for some reason. In terms of lumbar fusion surgery, traditional lumbar fusion surgery involves a lot of what's called soft tissue dissection. Lumbar spine is really deep in your body and is basically in the center of your body. There is no easy way to get to it. Whether you go through the front, through the side, or through the back, it's a long way down to the spine. So traditional surgery, you have to make really big incisions just to see the anatomy, to make sure that you decompress the nerves properly, make sure your implants and your instruments are going in the right place, because if you put stuff in the wrong place in the middle of the body, really bad things happen. So you have to make big incisions just to see, make sure it's safe. Problem with that is you're creating a lot of collateral damage. Most typical spine surgery is done through the back, and typically your collateral damage is you're cutting a lot of muscles off the bone, and you cut them and you stretch them away from the bone. It allows you to do the surgery safely and you do what you need to do, but the problem is you cause huge injury to the muscles. Half of the muscle basically turns into scar after that because you disrupted its blood supply and disrupted its nerve supply. So most of the time when patients get stiffness after lumbar fusion surgery, it's actually not because of the fusion itself, but because of all the injury to paraspinal muscles that you have caused. So what I've been doing for the past 6-7 years or so, I kind of trained myself, went to a lot of courses, followed a lot of expert surgeons and learned how to do it. So I do what's called minimally invasive lumbar fusion, where we still do the same nerve decompression, nerve and spine fusion, but now do it through a lot smaller incisions with a lot of less soft tissue disruption. So you don't destroy that muscle, you get less pain, you get less bleeding, a lot less chance of infection, about 5 times lower chance of infection, and people recover a lot faster. So my patients, instead of staying in a hospital 3 to 5 days, which is normal for an open lumbar fusion, most of my patients go home the next day simply because there's no reason for them to stay in the hospital. They're allowed to walk right away. They haven't lost enough blood. We don't do any blood transfusions or anything like that. So that's another subspecialty of mine, is what's called minimally invasive lumbar fusion. It is more complicated technically, and it does require additional training, but it's a huge benefit to my patient and really kind of transform my practice and allows me to help my patients a lot more. So it helps both young and old patients. In terms of young patients, it allows them to get back to their function, to their work, to their normal life a lot faster. With older people, traditional lumbar fusions, they actually may not even be a candidate for, because the surgery is so huge, it's too dangerous for them. But if I do it in a minimally invasive fashion, I can actually get away with offering that surgery to them and making them feel better and improving their quality of life without putting them under a lot of risk. Same applies to really obese patients. Obviously, we're always trying to get them to lose weight before spine surgery. Unfortunately, sometimes it's difficult to do. They can't really exercise much because everything hurts so much. It's really hard to get them moving. So sometimes you end up still doing surgery on them. Traditional open surgery on obese patient, you at least double your rate of complications. But if you do it in a minimally invasive fashion, the incision is actually exactly the same size. It's just the length of the retractor to get down to the spine is a little bit longer. So you make it a lot less risky, so you can actually offer that surgery to those patients. So a lot of times what happens is I get an obese patient, I do surgery on them. After the surgery, they feel better, and now they can actually lose weight because they're moving around. I just recently had a patient who I did surgery on in May, and I just saw him a couple of weeks ago. He has already lost 28 pounds and continued to lose because now he can walk. His back does not hurt him anymore, and that's a typical story for that.
Well, that's good to know. I mean, you have people, because we have such a big obesity problem, that if you can do something that can help them so where they can become, more mobile and they can get moving around more, because then they can do some physical activity and start to lose the weight and all that body fat, and really minimize not just correcting the back, but then they're also able to lose body fat and exercise and improve their health as well too.
Yeah, and everything else becomes better. Their diabetes gets better, heart health gets better, so it's a very good option to have.
Now, how long have you been doing the minimally invasive on the lumbar spine surgery?
Probably since 2012. When I graduated from spine fellowship, most traditional spine fellowships in America so far do not teach specifically minimally invasive fusion. It's something you basically have to train yourself separately. So I went to a lot of courses and learn how to do it. Now I actually train other surgeons on how to do the minimally invasive surgery. I'm actually traveling to New York later this week to do a teaching course on that.
Oh, wow.
Another, I guess, to expand on that, what I've been doing here since April, there's actually a spine robot which allows you to do that minimally invasive surgery even more precisely.
You were talking on the phone,
Yeah. So I've been using that robot to do my minimally invasive surgery. It makes the screw placement even more accurate. I scan the patient's spine with a CT scan before the surgery, and I get to basically pre-program all my hardware placement prior to surgery. That way, during the surgery, it's actually a lot faster to do, so surgery becomes quicker, which is also safer for the patient. But I basically just push the buttons and execute the plan. The robot aligns a special retractor that allows me to put the screw in the right place with sub-millimeter accuracy, so it basically makes minimally invasive surgery even less invasive and safer and more predictable. So that's another kind of step I've just started doing, another next evolution in minimally invasive spine surgery for lumbar fusions.
Wow, let's talk about advances in technology. Wow, that's pretty incredible.
It's exciting time to be in spine surgery right now. There are a lot of improvements going on.
It sounds like it, based on what you're telling me, and then the article, and then when we spoke on the phone last week as well too. It sure sounds like it, and it's just good for like you said, the overall health, and be able to benefit people, less time recovering, less collateral damage. Because like you said, when you're doing those other surgeries, not only do you damage the muscle, I think you were saying in that article that you wrote, there's also potential damage to the other discs surrounding the area that you went into. So
yes, exactly. If we can avoid fusion with disc replacement like we do in the cervical spine, you significantly decrease the risk of what's called adjacent segment degeneration, or getting arthritis earlier than you should have otherwise, just because you had fusion surgery. So with disc replacement, avoid that. With lumbar fusions, like I said, it's still a fusion, but you disrupt the muscles less. So you still protect that level above and below, and theoretically the chance of repeat surgery should be lower with minimally invasive surgery in the lumbar spine, even if it's fusion. That surgery hasn't existed long enough, so we haven't been able to prove it with studies yet, but those are coming and they're studying that right now. So very soon we'll have published articles showing that with minimally invasive fusion, the risk of additional surgery down the road will be lower than with traditional open fusion in the lumbar spine.
Then what is the traditional length when someone goes into, if they have lumbar spine surgery? How long, how many years is that good for?
Sure. There's really no one number, but statistically speaking, with traditional open fusion, whether it's in your neck or in your lower back, once you fuse, let's say L4-5 level, L3-4 and L5-S1, the level above and below have to move more to compensate. So statistically speaking, you get 3% risk of adjacent segment degeneration per year for every year you live beyond your fusion surgery. So at 10 years, it becomes a 30% chance that you will have a symptomatic adjacent segment degeneration. In 60 years, it becomes a 20%, I'm sorry, in 20 years, it becomes a 60% chance, and so on. So basically, the younger you are when you get your first fusion, the higher the likelihood of you to eventually get another one. How long it lasts really depends on the patient. There's so many variables. I've had some patients where 2-3 years later, they came back in another fusion, usually because they're out of shape and did not do what we wanted them to do to prevent the other disease. I have some patients that had fusions 10-20 years ago and they're still going fine, and the next level may look kind of iffy on the x-ray, but they're not really feeling any pain, so we'll leave them alone.
Okay, so yeah, obviously after the surgery, maintaining or increasing your fitness level and
very important.
Maintaining or improving your health is a big part of it. So.
Yep. Oh yeah. Basically, I'll tell them you have to do maintenance of your spine for the rest of your life. It's like changing oil in your car. You got to do it, otherwise it's going to break down.
Now, when you talk about maintenance of your spine, what does that all entail?
Range of motion and core strengthening. Basically, keeping your spine in proper alignment and keeping properly balanced muscle envelope around it to keep you in proper posture. The more proper your posture is, the less stress you're going to put on those additional discs and joints above and below fusion, the less likely they are to deteriorate and cause more pain.
Okay, and posture is obviously a big part of it. So,
yep.
Are there any certain? I mean, we have a lot of people, like I said, fitness-wise, and I have, obviously a lot of clients I work with. Are there any certain exercises or movements that you think would be something that you would avoid, or maybe, be cautious about and about doing?
So I wouldn't say there's one particular exercise that is terrible. I mean, deadlifts are, if you want me to name one, that would probably it. However, it's not necessarily that exercise is more of a form. There's nothing wrong with deadlifts. What's wrong is a lot of people, when they do them, they do not have proper form. So it's not necessarily the exercise itself. If done properly, in proper form, any exercise can be good as long as you know what you're doing and doing it right. Doing exercise where you basically lifting excessive weight more than you really should, instead of doing kind of low weights and higher reps, or just doing exercise with improper form, which usually means that you're lifting too much weight as well. That's the most common reason people have improper form. They bench press and they start arching their back, things like that. So it's not necessarily the exercise. I don't tell them don't do exercise. If that's what they like to do and that's what keeps them fit, I'd rather them do that than do nothing. So, for example, runners, theoretically speaking, running is just jumping forward constantly. Theoretically speaking, that every time you land on that foot, it's a shock to your disc. So yes, potentially it may cause the disc to degenerate faster. However, if I tell a runner not to run, they usually just walk out of the office and don't want to talk to me anymore. People who love running, they love running. So I would not dare take that away from them. And I would rather them run as their fitness, if that's the only thing they're willing to do, than them sit on the couch and do nothing. That'll be far more dangerous for their spine to be deconditioned than for them to be a runner.
Gotcha. Yeah, and I'm sure, like, when you talk about the deadlifts, I mean, obviously people lifting with like a rounded back, or any type of lift where you're subjecting the disc to
excessive stress,
pressure. So yeah, I've always stressed the importance of form with clients and with anyone. I've talked about it many times on these videos and in this group, but the proper form is so important in anything you do, to not just work the muscles correctly, but just to make sure you stay safe. I had a post a while back, and I think I mentioned this to you when I was talking to you on the phone, that there's a study, it was by, I forget what, it's a Safety Council of something or another, American Safety Council or something, but there's a study they did in 2017 that physical active exercise and exercise equipment was the #1 cause of injury with people, more so than football, baseball, basketball, any of these other sports. And I think probably the number one reason is because people are exercising in poor form and doing stuff incorrectly, or not warming up correctly, and lifting too much heavy weight, like you said, more than they can handle.
Yeah.
So.
Exactly. And because when they participate in sports, typically there's a coach, there's a trainer involved, there's someone watching them, making sure they do it correctly and they keep proper form, keeping them safe. When people go out there and do exercise on their own, unless they've been properly educated on how to do it right, they're obviously more prone to injure themselves.
Gotcha. Well, that's great. I mean, it seems like we got a lot of good information from you, Doctor. I appreciate you really joining us. If there's anything else you feel like you might want to add, go ahead and feel free to. Otherwise, I think we got a lot of good information out there, and I think it was definitely very, very informative.
Yep. No, I mean, I think we had a great discussion, kind of covered a lot of points, but yeah, biggest key takeaway that you and I keep repeating is, the best way to avoid seeing people like me is maintain proper range of motion, proper core strength, avoid gaining excessive weight. If you do that, the back does not have to hurt. It does not have to be a disabling thing, and you can have a good quality of life.
Great points. It's a lot of good information, and I really appreciate you joining us. And thanks again. And the video will be up here for anyone else they can always log on into the group and see the video at any time. So,
great.
Thank you.
All right.
Appreciate you joining us.
Have a good night.